Welcome to the Anesthesia and Perioperative Medicine channel. Willkommen auf dem Kanal für Anesthesia and Perioperative Medicine. Bienvenido al canal de Anesthesia y Medicina Perioperatoria. Today, we're diving deep into what is, without a doubt, one of the biggest challenges we face in the operating room, the repair of a thoracoabdominal aortic aneurysm, or TAAA. Our goal here is to really unpack the latest thinking on how we manage these patients anesthetically, and, most importantly, the strategies we can use to prevent some of the truly devastating complications that can arise. So here's our roadmap for this explainer. We've broken it down into 6 main parts. We'll start by defining the problem, the anatomy of the challenge itself. Then we'll walk through the entire perioperative journey, from the critical preoperative assessment into the thick of intraoperative management. We'll spend a good amount of time on the absolute cornerstone of this procedure, spinal cord protection. After that, we'll look at what can go wrong postoperatively and how to manage it, before finishing up with the look at some really advanced cases and where the field is headed. All right, let's start at the very beginning with the fundamentals. Understanding how these aneurysms are classified, it's not just some academic exercise. It is truly the bedrock of our entire anesthetic plan. Knowing the classification allows us to predict, with pretty good accuracy, the specific physiological insults our patient is about to endure. It lets us prepare our strategy before we even walk into the room. So what are we really talking about when we say TAAA? Well, at its core, it's a weak ballooning section of the aorta that spans from the chest down into the abdomen. But what makes this one of the most formidable procedures in all of surgery? It's the real estate. This aneurysm involves the takeoff points of the critical arteries that supply everything, your gut, your liver, your kidneys. And just as importantly, it involves the tiny segmental arteries that are absolutely essential for perfusing the spinal cord. This complex, critical anatomy is the root cause of every single one of our challenges. Okay, now this table is where it gets really practical for us. The Crawford classification is basically the universal language we use to describe these things. Let's break it down. A type 1 starts high up in the chest in the descending thoracic aorta and stops just above the renal arteries. Type 2? Well, type 2 is the big one. It's the most extensive, starting high in the chest and going all the way down past the kidneys. Type 3 starts a bit lower in the chest, and type 4 is basically the entire abdominal aorta. There's also a type 5, which is sort of a mix. The key takeaway for us, the more aorta that's involved, especially with a type 2, the longer the clamp time, the greater the physiological storm, and, as we're going to see in a bit, the exponentially higher the risk of spinal cord ischemia. Right, so moving on to the preoperative phase. With a surgery of this magnitude, a meticulous, almost forensic evaluation is completely non-negotiable. Our job here is to be detectives, to find every potential vulnerability, every comorbidity, and optimize it as much as humanly possible. This is also where we lay out our blueprint for monitoring so we can see every physiological shift the second it happens. This prep work is truly where a good outcome begins. We have to systematically go through every single organ system because every one of them is about to be put through an incredible stress test. Cardiovascular health is obviously number 1. The heart is going to see wild swings and afterload, so we need to know everything about its function. Lungs are next. These patients are often longtime smokers with underlying COPD, and they're facing a massive operation. Then there's the kidneys. Baseline renal function is probably one of the single best predictors of postoperative acute kidney injury. And of course, we need a detailed neurological exam to have a baseline to compare to post-op, and a full hematologic workup because the potential for massive blood loss is very, very real. Okay, now we're in the OR. This is it. This is where we, as anesthesiologists, have to pilot the ship through a physiological hurricane. Our job is a constant balancing act, maintaining hemodynamic stability in the face of chaos, protecting every vital organ from ischemic injury, and managing a potential coagulopathy, all while the surgery is creating its own controlled trauma. It's hours and hours of pure vigilance and making rapid, precise decisions. This table really drives home the level of monitoring we're talking about. This setup is our mission control. Every single line tells a critical part of the story. We usually place the arterial line in the right radial artery. Why? Because the aortic clamp might be placed proximal to the left subclavian artery, which would give us a falsely low and, frankly, dangerous blood pressure reading. The femoral arterial line is our only window into what's happening below the clamp. It tells us about distal perfusion. Of course, we need multiple large-bore IVs and a central line because we know we're going to be giving massive amounts of fluids and drugs. A PA catheter can give us advanced cardiac data if we need it, and the TEE is our eye inside the chest. It gives us a real-time, beat-to-beat assessment of cardiac function and volume status. It's absolutely indispensable. Now, this slide captures the two most terrifying, most hemodynamically violent moments of the entire surgery. First, the surgeon calls out, "Clamp on!" And in an instant, the heart is pumping against a brick wall. The afterload goes through the roof, proximal blood pressure skyrockets, and the left ventricle is suddenly at risk of acute failure. Our job is to be ready to aggressively vasodilate with something like nitroprusside to take that stress off the heart. Then, maybe hours later, comes the call, "Clamp off!" And the physiology flips 180 degrees in a heartbeat. The entire vascular bed below the clamp suddenly opens up, causing a catastrophic drop in blood pressure. At the same time, a toxic cocktail of ischemic byproducts, lactate, potassium, washes out from the lower body and hits the central circulation, causing profound acidosis and vasodilation. Our management has to flip just as fast. We go from vasodilators to pouring in volume and starting potent vasopressors like norepinephrine. These are two completely opposite physiological states that require completely different interventions, and the transition happens in seconds. And that brings us to what is, for many of us, the absolute heart of the matter in modern TAAA management: protecting the spinal cord. Paraplegia, it's the complication that everyone in the room fears the most: the patient, the surgeon, and certainly us. Preventing it isn't about one single magic trick. It's about a coordinated, multi-layered defense that starts long before the first incision and extends well into the postoperative period. So just how real is this risk? This chart gives us the hard numbers, pooled from a lot of different studies. Overall, the risk of a permanent spinal cord injury is about 3.3%. Now, what's really interesting is the comparison between open and endovascular repair. You can see that endovascular repair does have a slightly lower rate, at 2.9%, compared to 4% for open surgery. But the key message here is that the risk is absolutely not zero with either approach. It remains a very real and significant threat, no matter how the aneurysm is fixed. And this is why that Crawford classification we talked about is so critically important. This table is stark. It directly links the anatomy of the aneurysm to the risk of permanent paralysis. Just look at the number for Crawford type 2, the most extensive repair. The risk of permanent spinal cord ischemia skyrockets to a staggering 13.4%. That's more than 1 in 8 patients. And why is that? Because that repair interrupts the largest territory of the aorta, sacrificing the greatest number of intercostal and lumbar arteries that feed the spinal cord, including potentially the all-important artery of Odom-Kievsky. This data tells us in no uncertain terms that a patient with a type 2 TAA is in the absolute highest risk category we can imagine. So how do we fight back against a risk that high? We throw everything we have at it using a multimodal strategy. There's no single silver bullet. It's all about layering protections. First, we optimize hemodynamics. We run the mean arterial pressure high, often targeting 80 to 90 millimeters of mercury, to physically push blood into the spinal cord's vascular network. Think of the spinal cord perfusion pressure, or SCPP, as a simple equation. SCPP equals MAP minus CSF pressure. This beautifully explains our second strategy, cerebral spinal fluid drainage. We place a lumbar drain to remove CSF, which directly lowers the CSF pressure. So, by raising the MAP and lowering the CSF pressure, we are maximizing that perfusion gradient from both ends. We also use moderate hypothermia, cooling the patient a bit to slow down the spinal cord's metabolic rate, making it more tolerant to ischemia. Surgeons contribute with techniques like distal aortic perfusion or by directly reimplanting critical arteries. And all the while, we're watching the cord's function in real time, using neuromonitoring like MEPs and SSCPs. It's a true team effort. Our job is far from over when the patient leaves the OR. In fact, the postoperative period is just as critical. This is where we have to be vigilant for delayed complications, including, ironically, problems that can arise from the very interventions we use to protect the patient in the first place. And here's a perfect example of that from a case report. On the left, you see the team putting in that lumbar drain we just discussed, but on the right, we see a postoperative problem. After they removed the drain on day 3, the site just kept leaking clear fluid. The team had to figure out if it was CSF or maybe leftover local anesthetic from an epidural. They did some simple bedside tests and confirmed it was, in fact, CSF. Their fix was to place a deep figure-of-8 suture, which you can see highlighted by that yellow arrow, and that finally stopped the leak. It's just a great reminder that even our best protective tools aren't without their own potential complications. And the slide really quantifies those risks in a sobering way. Yes, CSF drainage is a cornerstone of spinal cord protection, but it is not a benign procedure, not at all. Spinal headaches are pretty common, as you can see, but let's look at the really severe complications. The risk of an epidural or spinal hematoma, which can cause permanent paralysis itself, is almost 1%. Intracranial hemorrhage, a truly devastating event, happens in up to 1.9% of cases. And most chillingly, there is a reported mortality rate that is directly attributed to the CSF drain itself as high as 1.9%. The takeaway here is that we are always walking a tightrope. We have to constantly weigh the very real protective benefit of CSFD against its non-negligible and potentially lethal risks. So what do we do when the worst happens and a patient wakes up or develops new neurological deficits in the ICU? We have to launch an immediate rescue protocol. This is a code-level emergency. The first thing we do is aggressively raise the blood pressure, often targeting a MAP over 90 millimeters of mercury to try and force blood to the spinal cord. Second, we open up that lumbar drain all the way, aiming for a CSF pressure less than 10, or even 0 if the deficits aren't improving. We are pulling out all the stops to maximize that SCPP. Third, we optimize oxygen delivery, transfusing to a hemoglobin over 10 and making sure their PA2 is perfect. And all the while, nurses are performing hourly, detailed neuro exams to see if anything we're doing is actually working. It is an absolute all-hands-on-deck crisis to try and salvage that patient's spinal cord function. Okay, for our last section, let's look at the real cutting edge. What do you do when a patient's anatomy is so complex, so hostile, that the standard playbook just doesn't apply? When a regular open or endovascular repair isn't an option? This is where true innovation and creative, outside-the-box thinking really shines, pushing the limits of what we thought was possible for these incredibly high-risk patients. Just take a look at this case. This is a 3D CT scan from a 39-year-old woman with Turner syndrome. And what she has is a massive thoracoabdominal aneurysm that developed after an aortic dissection. But here's the killer problem. The true lumen, the original channel of the aorta, is severely squashed and narrowed by the high pressure in the false lumen. This makes a standard endovascular repair where you normally place the stent graft inside the true lumen completely impossible. The team had to invent a whole new strategy for her. And this was their incredibly elegant solution. Let's walk through it because it's brilliant. First, over several stages, they surgically created bypasses to all of her main abdominal and thoracic vessels. Then came the masterstroke. They created what they called a perfusion branch. They actually went backwards from one of the new grafts through her celiac artery and threaded stents into that compressed true lumen. This step is the whole key. It created a temporary lifeline, a dedicated channel to keep blood flowing to the critical intercostal arteries that come off that true lumen. With that lifeline in place, they could then safely deploy the main large stent graft inside the false lumen to fix the aneurysm. But they weren't done. Weeks later, they brought her back for the final act, a test occlusion of that perfusion branch, to see if the spinal cord could handle it, and then, finally, permanently plugging it. The whole idea is to precondition the spinal cord, to give its collateral blood supply weeks to grow stronger before the final step. These images here show that crucial safety check. This is amazing. The patient is actually awake for this, just under local anesthesia. In the images on the left and in the center, you can see that little angioplasty balloon, marked by the arrows, inflated inside the perfusion branch. They're temporarily blocking the flow. For 10 minutes, they stood at the bedside and did a detailed neurological exam on her. Can you move your legs? Can you feel this? Because she remained perfectly normal neurologically, it was definitive proof. It proved that her spinal cord's collateral network had developed enough to tolerate the permanent occlusion of that branch. Just incredible. And on the right, you see the final angiogram showing all the visceral grafts are working perfectly. And this is the final result, a beautiful 3D reconstruction post-op. The aneurysm is totally excluded, the grafts are working, and the arrows are pointing to that now permanently plugged perfusion branch. This case is just a phenomenal example of a staged, physiology-driven approach to preventing paraplegia in a patient who, by any traditional measure, might have been considered inoperable. I think this quote from the authors of that case report really just says it all. The challenges with these post-dissection aneurysms are just enormous, and spinal cord ischemia is always the #1 problem we're fighting against. What they did was demonstrate a new path forward, a way to tailor a strategy to a specific patient's anatomy to dramatically lower that risk. It just highlights how important it is for us to keep innovating. And so this all leads us to our final, and I think very provocative question for the future. We've just spent all this time talking about our current gold standard, which includes CSF drainage, a technique we know is effective, but which also carries its own serious, sometimes fatal risks. So we have to ask ourselves, where are we going from here? Will these kinds of elegant, staged endovascular solutions become more common? Or maybe, will our neuromonitoring technology get so good, so precise that it can guide our interventions in real time and make these prophylactic and risky measures totally obsolete? That's really the challenge for our entire specialty in the years ahead. Thank you for joining me for this explainer.